This next section is called Investigating Outbreaks. And what you're going to become after reviewing this section is an infectious disease detective. As you recall, epidemiology grew out of infectious disease. And if you've ever played Clue, the Great Detective Game, or watched Murder, She Wrote, starring Angela Lansbury, the processes are very similar. So we start with clues and information to arrive at the type of disease that we would need to either um, prevent, protect against, or control. So I'd like to talk to you about how we define disease. Now, entire courses are dedicated to this particular topic. So I and many of you have had experience and background in these areas as well. But a disease, as you can see, is we define it as an interruption of life or a cessation or a disorder of bodily functions, systems, or organs. And it arises from an infectious agent. We'll talk about some of the terminology we will use from a public health standpoint to describe how um, diseases influence humans, or a disease can occur because of some inherent weakness. Um, it would come from a genetic background, lifestyle, or environmental stresses or stressors. So you can probably think of many different circumstances. Let's just take lifestyle because we focus so much on those because those are the ones that are preventable. And we've talked about those earlier. For example, inadequate sleep, poor diet, lack of exercise, etc., etc., or environmental air quality is another one that would have a negative effect on human functioning. We know that factory life or factory work in America is still a very dangerous. It's still a very dangerous environment, and so I ask you really to think about those kind of circumstances as well. We have factories in this area, for example, that produce a lot of noise pollution, and as a result of doing that, people have hearing loss. So I'm trying to give you as many factors to take into account when we talk about disease. And so when we look at wellness, we're also talking about physical disease, and we're talking about mental disease. And we recognize that when people are under stress for long periods or they confront major life events, it often has a very deleterious effect to their bodies and their functioning. In fact, certain parts of the brain are actually eaten away due to prolonged stress. Now, I want you to notice that we're tr- trying to look at the cause, the determinants, or the agents of a disease, and the mechanisms by which they spread remains a primary focus in epidemiology. Because if we can't detect what the disease is, then we have no influence over how it spreads or the determinants or the distribution of the disease, or whether whether we need to take certain actions or not. And you're well aware of etiology, and that has to do with the science and study of the causes of disease and their mode of operation. So As I say, I'm going to give you some rudimentary, and this is about the end of the rudimentary aspects of it, and then go to more of a public health focus. But all of these terms come together when we're talking about the Control of Communicable Diseases Manual. Um, One of the terms that you need to become familiar with is an agent or a disease agent, and you can see it's a factor that promotes a disease. And this can be microorganisms, chemicals, air, water, waste, whatnot. Now, the traditional thought is what we'd always hoped for in the early sciences, that we had one disease agent or determinant that caused a single disease. Um, Oftentimes, what we see is that we have multiple disease agents that lead to a disease. If you take for a minute and you think about obesity, for example, we have probably 30 factors that we look at that are influenced or related to obesity. So we have 30 or 40 disease agents that have an impact on whether or not somebody is obese or not. And this is what makes progress slow in certain scientific areas, and it makes those diseases particularly difficult to treat and affect. Um, of course, we have other types of diseases that we don't do so well with either, that might be viewed as simpler, and I'm not certain that they are by any means, but we might look at the spread of flu, and what are the types of actions, public health actions, that we would take in order to decrease the likelihood of influenza morbidity and mortality. I want to introduce you to some key terms in epidemiology and public health, and I'm taking these terms and I'm looking at them, and they come right from the Control of Communicable Disease Manual. And I want to try and distinguish these terms because these are the terms that you ought to begin to use and you ought to become familiar with. And there's a lot of confusion about these terms, and hopefully I can make this as simple as possible. A reservoir is a natural habitat of the infectious agent. For example, you could think of a pond or a pool of water, and where a mosquito might breed or live. So, and it multiplies, and I think that's probably the best way to look at it. Sometimes we refer to it as a hotel, just the living quarters, and of the disease. It doesn't have anything to do with its spread. It's just where the disease resides. So, and we're interested in its development. How quickly does it multiply? How quickly in a pond would we have more capability of disease? The next term I want to introduce you to is mode of transmission. And how do we get a disease from one individual to another? So, and what we would talk about again is the infectious agent. How is it spread? And of course, it can be airborne, it can be waterborne, it can be vehicle-borne, it can be food-borne, or vector-borne. And I'll go through and I'll define each one of those terms for you. A host is a person or place where, a person, living animal, for example, birds or arthropods, insects that harbors a disease. So we're dealing with where it lives, and you may be the place where a particular disease would live for a while. For example, influenza, pneumonia, and it could be acute or chronic. Wouldn't make any difference. Another public health term is the period of communicability, the time that you're contagious or infectious. So, if you have influenza, how long a period is it that you're likely to infect somebody else? When is the time that people should avoid you or you should avoid connection with others? And we're trying to develop and think about policies in this area, and they aren't very widespread yet. We still encourage people to go to work when they're ill, and the fact is that the mode of transmission of the disease would come to play, and the host would contaminate others in a variety of different ways, and I'll talk about how that disease gets spread here in a moment. And last is susceptibility, and you can sort of see this as what kind of shape are you in? How well have you taken care of yourself? And there's a number of things that influence and affect that, and we talk about them routinely. And if you're are you run down? Are you overstressed? Do you smoke? Do you drink alcohol? Do you not engage in physical activity? What are the behaviors that cause you to be more susceptible to the disease? And of course, there's a wide variety of factors that come into play. But if we help individuals focus on this, they ought to have more immunity and therefore be able to ward off disease. Now, I want to talk about two main ways to transmit disease. That's direct and indirect. And if you look at the direct methods, most people think that these are the quote the fun ones, and you can. I'm not going to ask you to comment on it, but maybe this is an easier way to remember them. The most direct transmission of disease is through touching, kissing, biting, coughing, and sexual intercourse. So these are the direct pathogens that get transmitted the most rapidly from one person to another. So you can especially see if you've got the disease, again, going back to influenza, touching, kissing, coughing, sexual intercourse, biting, all those things are more likely to lead to disease. Now I want to switch for a moment and talk about indirect transmission of disease. And there are a number of ways that this happens, and they happen through fomites. And as it says here, that's an inanimate object. And I'd like you to think about fomites just for a minute, because there's all kinds of them in which bacteria and viruses live on some fomites for 24 to 48 hours or longer, some of them even days. So when we think of a fomite, we think of a door handle. We think of a pen or a pencil. We think of a coffee pot or a coffee pot handle. We think of a telephone. We think of the faucets in a bathroom. The toilet paper dispenser in a bathroom. Anything where the public comes in frequent contact with an inanimate object, doors that don't have handles but have metal bars, anything that many people touch is a way to spread disease. We'll talk about contaminated food. You know something about contaminated water and infected insects or vectors, and that's another public health word that you will come to hear and appreciate a lot. So a vector is something that you ought to think about as well. Now, I want to talk about the indirect transmissions of disease, and there are three major categories. They're vehicle-borne, food-borne, and vector-borne. Now, when we talk about vehicle-borne, we're talking about fomites, and these are all inanimate objects that need infection control. They need to be cleaned. They need to be sanitized. And I've mentioned the doorknobs, but you can think about tabletops and desks and the break room, the machine, the candy machine, or any of the dispensing machines. The button on the water cooler is one of the filthiest. Keyboards, that's something that everybody uses, and oftentimes they share. Headsets on phones, cooking surface, and the toilet lid, and approximately to the proximity of your toothbrush to your toilet. One of the things they recommend is that you, every time the toilet flushes, it sprays, and there's a vapor that's left in the room, and if your toothbrush is close to the toilet, you're contaminating your toothbrush, so you'd want to move that further away from it. Foodborne transmission has to do with contaminated foods, and those that are well known are raw or undercooked chicken or eggs, and or anything that's contaminated during the growing process. We've heard about spinach, for example, and it being infected by infected manure. So it's important to take that into account. Now, vector-borne transmission is a pathogen is transmitted via an intermediate organism, and for example, pig and flu, or the swine flu, and mosquitoes and malaria. Now, we also know that 75% of all diseases are transmitted through animals to humans. So we have an area called zoonosis, and people frequently wonder why veterinary medicine is so interested in epidemiology, and that's one of the reasons because of this statistic. The military uses veterinarians to inspect meat to make certain it's non-diseased and it's consumable and proper for consumption. I'd like to talk about the steps involved in investigating an outbreak. Now, we're well aware about the difference between an outbreak, an epidemic, and a pandemic. And the first thing that we need to do anytime that we're in an investigative process and we're trying to determine what the disease is the disease has to be diagnosed. Now, it's not always immediately diagnosed, and I'm going to show you ways that through information that we can come to a conclusion without serology or taking blood or using any other means to know what the disease is. So we have to be always clear of what the criteria are for what constitutes a given disease. So that's the important first step. The important second step is we need to know the endemic state compared to whether there's been a change. So the endemic state, again, we can think of the baseline. And if we have sharp spikes or changes in the occurrence or incidence rate of a behavior, then this is a pretty important clue that we've got a problem that's going on that we may need to do something about. Now, I've mentioned the criteria, especially with waterborne and foodborne diseases. I've already mentioned the criteria for when we're looking at diseases, we're always comparing it to the endemic state, and we want as long a period preceding the disease as possible so we can see whether the spike is really truly significant and does in fact change. Now, when I go back to a foodborne or water disease, the first case or case one is the endemic state, because it would be the steady state. It's not, if we only had one case, we wouldn't count that as being a foodborne or waterborne outbreak. So it takes at least two cases to qualify it. But saying it differently, the expected would be one case, and if the observed was greater than the expected, that would be two cases. So if we observed two cases expecting one, in this case two and greater would indicate some kind of problem. Now, also you should note that we're interested not only in those people who are ill, and we want to interview them and find out as much about them as we can. And I'm going to talk about this later so that you understand that the collection of data from individuals about the various circumstances and consequences that they have encountered are very important to this entire process of deciding on whether we have an important disease worthy of our attention and future steps. Now, we want to define the distribution, and you know that that this has been something important to us all along. And if you go back and you look at the initial definition of epidemiology, the first word in it is a distribution, and we have those whole host of words that have demic in them that help us define that distribution. But primarily what we're always looking at is whether the observed is greater than the expected. We wanted to define the case, and we want to define the population at risk. So if we had an outbreak that was restricted to a small location, we would want to know, we would want to look at two groups, those people that became ill and those people who didn't become ill. But still, the total population would be the denominator. The total number of people present at the event would be the denominator, and those who became ill would be the numerator. Okay, the next step is we want to find the distribution, and as you remember, we talked about the distribution before in the definition of epidemiology. I'm hoping I'm not repeating myself to you because we stopped here for just a second. But there's all kinds of terms that end in the demic that help us to define the distribution. But if we were, let's take a foodborne outbreak, and that's what just to as one means to focus our attention. If we had a church picnic and we had 100 people that attended, the population at risk would be that those 100 people. The numerator would be those people that became ill by eating a particular food. So we would want to be very um, sure about caseness, or what is the case, or what are the criteria for somebody being for us to consider that somebody has a foodborne illness. Now, person, place, and time is always important in any of our analyses of a problem. We're going back to descriptive epidemiology again, and we want to consider difference in variables. For example, we could look at chocolate or vanilla ice cream associated with the illness, or we could look at any number of other foods and factors. And I'm going to show you forms used by our public health agencies locally and statewide and nationally to investigate a foodborne outbreak. I'm sorry I didn't keep up with you there, but I'm certain you've been following along and you've been keeping up with me. So if I get behind, just do that. Okay. And the next thing we were really wanting to do is we want to develop a hypothesis. And when we start developing hypotheses, we're going into analytic epidemiology, and we're asking, what is a determinant? What is the agent? What's a vector or the food that seems to be associated with the foodborne illness? And so we might be investigating not only those people who came, but those people who left the foodborne event. So we might be consulting physicians, hospitals, and others to find out our denominator or the number of people at risk. So that's very important to us, or to help us with the numerator to know how many became ill. So we're always interested in these two factors, the agent, and always looking at the total number of people who have become ill, who have been associated or affiliated with the foodborne outbreak. Otherwise, we can't be precise and we don't know the size or magnitude of the problem. Now, we ultimately want to recommend prevention, protection, and control measures. And when we, for example, if we have a foodborne outbreak, what caused it? We have food safety as a part of public health. One of the things we know that if you go to a delicatessen, they use a meat slicer, and inside that meat slicer, after you clean it, is a little pocket, and sometimes that little pocket is not cleaned well, and it will cause bacteria. So we very much want to know what the etiology or the origin of that particular disease is. And once we have the opportunity, we can begin to review several of the symptoms, or the incubation period, the period of communicability and susceptibility in our manual, and we can look under specific foodborne diseases to see which one might explain the symptoms and the illness itself, along with its duration, and what treatments would be appropriate. This particular manual outlines all kinds of measures and steps to take, so a person is not left to their own devices. It's already been, all the work has been done for them. Now we have to report the investigation, and We have specific forms for this. This is not a new topic or a new area of concern in terms of public health. So um, we want to review the factors leading to the type of distribution. Okay, are we dealing with an outbreak? Has it gotten more serious than an outbreak? And is it beginning to spread? We want to evaluate whether our intervention methods have worked. Have they been effective? And we also want to recommend the appropriate intervention methods that should be used uh, to keep this problem from happening in the future or to prevent its its reoccurrence. And again, I recommend Heyman in this control of communicable disease manual. It's interesting that this manual was first published in 1915, and there are even downloaded versions by phone now, and many of our epidemiology, public health people have those downloads so they can consult the manual rather quickly and search it. So I highly recommend if you're going to have contact with the patient population or you're going to be involved in any way in any of these kinds of outbreaks that you become familiar and buy this book. I think it's well worth it. And you can usually get copies that do not cost much because you can get them online. You can get used ones. Okay, preventing future outbreaks. Now, when you look at public health, it's got four major arms, and this is always arguable, but um, we talk about reaching the public through health education, and I'm going to start from the bottom and go up, and that's working didactically, teaching people like what I'm doing with you, and they could be on an individual basis or a group basis. We have health promotion, and this is a broader means of this is a population-based approach, and we work with flyers and brochures and radios and television and all kinds of media that are designed to reach a large number of people. There's a book called The Pink Book, and you can Google it under Pink Book, and here's its address, and it tells you how to design public health interventions that are population based from a communication perspective. Another area of focus has to do with policies. And policies are important and usually are not law, but are very important to the health of the individuals that we come in contact with. Perhaps you've been to a restaurant where a person serves food, wears a little apron with money, and makes change with that money. Um, and doesn't involve a register, a cash register, or anything else. Of course, those procedures I haven't seen recently, but they were very much in practice at one time. So 80% of our money has drugs that are in the fibers of the money or in the paper, and you never know where money has been. So you see signs in restaurants about food handlers washing their hands, and they're not to engage in of handling of money and food either. But I'm not certain that plastic credit cards may not carry germs too that could be contagious and cause a foodborne outbreak. Now, we also propose laws, and I'm going to talk to you about holding temperatures of certain foods. And you can laugh about this, but you might think about the next time you go someplace, especially to a smorgasbord, about taking a food thermometer to see whether a food is being held at the right temperature, either hot or cold. Um, Now, another means, and I don't want to overlook this, is that we are using technology. Technology is exploding, and we're combining it in multiple ways, and we're also combining it and using it in public health interventions. Um, one project I'm aware of that's operating in Texas is um, they use text messaging to remind people to engage in certain behaviors. And of course, you see Facebook and blogs, etc. We now even have software that we use to analyze this information. In fact, we use this software um, not too long ago in the last flu um, pandemic, and it was more effective in predicting when the flu would occur in a given area than standard survey means. So surveys will be used probably in some instances, but I suspect there will be a decline in their use because when we deal with electronic social media, we're getting real time data. We're getting data that occurs immediately, and we're able to process it and analyze it and get a lot more information from it than by other means. Now, I want to talk about a foodborne outbreak. Um, um, the primary cause is of contamination is improper holding temperatures, poor employee hygiene, for example, going to the restroom, especially if there's bodily functions involved in. We have noted that in restaurants in Bloomington and other places that if fecal matter comes in contact with food, oftentimes that can cause a foodborne outbreak. Inadequate cooking, contaminated equipment, and food from unsafe sources, and I'm just giving you examples here. Fish from waters with high mercury concentrations, like from Lake Michigan and in Indiana waterways. If you go to some parts of the world living right on near a waterway or an ocean or a river or a lake is a wonderful opportunity. We here in Indiana sort of watch those because of the contamination effects. Now, I also wanted to let you know it's that in some states, for example, that in California they will have a triangle in the window, and if after a food inspection has been conducted with a certain restaurant, and a green triangle means that there's none to minor health infractions after the inspection, and a yellow means that there's more serious health infractions that can be remedied quickly without too much effort. And red means it's serious, and often what they do is they will close a restaurant in those instances. We don't have anything like that I'm aware of in the state of Indiana. We do publish in the paper on Sundays those local food establishments, if they've been inspected, that don't comply with proper regulations. So that's an important element and aspects. And we talked about slicing of meat and whatnot, and being careful about that, and hopefully the equipment has been cleaned and sanitized properly, etc. And that's what a health inspector will do in looking at food safety. Now, this is a foodborne outbreak form, and you can see this is a form used by the state of Indiana. And not that I expect you to memorize and know everything on this form, but this this lets you know that this is an important form, and that foodborne outbreaks are taken seriously. Um, and it is much like the form you're going to see next from the CDC that identifies the food responsible for the outbreak. So the point is that I'm teaching you procedures that are used routinely. I'm teaching you vocabulary that is central to public health and communicating with public health officials. And I'm teaching you ways to investigate a foodborne outbreak in a systematic way so that you arrive at the right conclusion, so we protect others that do not have the disease or the problem currently, and we offer proper treatment to those who do. Now, you'll notice in reviewing this form that they ask for a lot of demographic information, name and age and occupation and race and all the things we would think of. And then they look at symptoms. And you can see the list of symptoms that they have there. They look at sources of positive specimens. Not always do they get the opportunity to get specimens, but if they do, they want to look at them, and they usually utilize a form like this for people who they know to have the particular disease. Now notice we're still talking about salmonella, and they're wanting to know, and I think this is particularly interesting because it's happening in our society routinely, or quite frequently, I should say, where people are dying from diseases that can't be treated or cured by antibiotics. MRSA would be one of them. SARS was one in, I think, 2005, where we weren't able to successfully save people's lives. They're wanting to know where all the specimens came from, and what physician is involved, and what commercial eating establishments did the person eat at in the last 5 days, because it's very important, because these are litigious matters. Often they will lead to lawsuits as to which restaurant's being blamed for a particular illness, and you can see why, because if a restaurant gets accused of supplying contaminated food, oftentimes the number of patrons declines quite rapidly. And now, what lists all group gatherings where food was served. So, did they go to a particular gathering like a wedding or a funeral or any number of other social events where a large number of people were present? Did they go to somebody's home? And what stores are they buying groceries from? Because we're looking from the old statement, or the new one is from farm to fork. So we're trying to look at every intermediary step in between, so we know the thread of contamination and where its origin is, because we've got to stop it at the source. And you can see the foods and that are listed here, and there are plenty of them, and they're looking, you can probably tell pretty quickly that they have to do with meats and eggs and things made with eggs. So they want to examine that carefully. Um, so, and of course, coming right up on the next page has to do with undercooked or meat or eggs. As I mentioned, the ones that precede it, the foods that precede it on the checklist fall under these two main categories. Other things that might influence whether or not you'd have a foodborne outbreak would be, or some kind of disease transmission that would cause illness would be wild birds and reptiles and farm animals and poultry and pets and whatnot, because all of these transmit disease. We don't think of it very often, but they do, and you just learned that 75% of the diseases that influence man are transmitted to him by animals. And of course, when we talk about wild birds, um, we talk about them being in contact with insects such as mosquitoes, and it's quite a vicious cycle to understand how we can stop that occurrence of disease transmission from happening. Okay, I think I've covered this pretty thoroughly in terms of the Indiana form, and of course you can make comments in the investigator's name and whatnot. Now, here's the national outbreak form from the CDC. What you'll find, and I'm not going to go over this one as carefully because I wanted you to see the Indiana form and become familiar with it. But you can see that the CDC form is a little more thorough because the intention is it can be used almost any place, and there is concerned about the tracking process as Indiana in terms of identifying where the origin of the problem occurs so they know what to do, whether they need to pull things off the shelf or just what is required in order to offer some control. So you can just sort of go through it, and incubation period is an important word that we're going to spend time with, and it comes from the Control of Communicable Diseases manual. And I'll talk more about it, and we'll look at duration of the disease as well, and we have signs and symptoms, and we'll discriminate primary from secondary cases. And so the process here is it's very similar but just more detailed, and when you have a chance you can go through it and look at it very carefully and see what the differences are. I think you'll enjoy the process, and I think you'll see that we're pretty active in this area about people not becoming sick by contaminated food or diseases being transmitted by other means. Okay, now, in other important terms that we want to identify in tracking a disease or investigating a disease has to do with the index case, and this is the very first person that has a disease. And why would we want to identify that person? Why would we want to go back and investigate and look at and identify the person who first has the disease? Why is that so important? The first thing we would do under this circumstances, we would interview this person. We would find out what they've been in contact with, what they've done, what foods they'd consumed, what symptoms they've had, how long has it gone on, or the duration of it. We would ask about, in other words, we would try to look at the reservoir, and all the other terms that we'd looked at before. We would be investigating to see whether or not this person could help us with the origin of the disease. Now, Another term that is important for you to know is the primary case. Now, the primary case is not an index case. An index case is the first person who has the disease, but this group is usually so closely internet or close to the index case that that it's hard to differentiate. Um, but these are the individuals who introduce the disease into a family or group under study, and not necessarily the first diagnosed case in a family or group, as I'd mentioned. So, and we may have co-primaries. So we may have not a primary case, we do have an index case, but we have primary cases. And so we often call these co-primary cases. Now, secondary cases, um, these are the people who got the disease from the index case or the co-primary cases. And I want to show you a diagram to help make this clearer as to what I'm trying to point out between the three different types. But we're trying, again, this is part of the investigative process, and we're trying to obtain information from each of these groups that's going to lead us to what the cause of the disease is, and how widespread it is, how many resources it's going to take, and what we're going to need to do to prevent, control, or protect people. So if we look at this together, you'll see that we're going to look at, we're thinking about the primary attack rate. Well, somebody asks you what the primary attack rate is, it's 100%. And that the reason it's 100% is because that index case is the one who gets the disease. There's one index case, so that makes 100%. So now the percentages are different with the secondary attack rate, and we're going to talk about this, and I'm going to show you how to calculate it and what we're going to do with that information. So this is what I was trying to talk about earlier, suggest that that co-primary cases really belong to the same generation of cases as the index case. But a secondary attack rate describes the spread of disease within a group, excluding the index cases and co-primary cases. So when you think of an index case and a co-primary or co-primary cases, they're so close in time that sometimes it's real difficult to separate those out. That's the point here. Now, let me show you in this example, we're going to use this example again, but if we talk about, here's an index case, and you can see the index case very clearly, and you can see the co-primary cases, and this is time across the bottom. You can see that closely following the index case are the co-primary cases. And the co-primary cases spread it to family or to other individuals. So you can see that with this top primary case, or actually a co-primary case, that this person is spreading it to 1, 2, and 3 people. Now, the dark circle means that the disease is not spread. And what occurs here is that this person has immunity to the disease, so it doesn't go any further. It doesn't go on to another individual. Now you can see in the case of the secondary, the second co-primary case, that the disease is spread to one person, it's spread to another person, immunity occurs and it stops here, but then all of this continues for a long time. So this one co-primary case influences many secondary cases. Now we can see with this, the third one, that it influences one individual and then immunity occurs. And then with this next one, the same one, it influences several different people, and you can see where immunity occurs. So when we look at this, we talk about index cases, co-primary cases, and from this black line forward, these are secondary and tertiary cases that occurred because of contact with the index case or the co-primary cases, and that could be from indirect or direct means of transmission. Okay, so as we go on to the next slide, let's do a critical analysis here to see how we would come up with the secondary attack rates of mumps. Now notice under this particular case it's broken down by age, and you've seen this kind of breakdown before in age categories. And again, this could be broken down by any demographic variable. It doesn't have to be by age. But let's see what we're going to do in terms of how we're going to calculate the secondary attack rate. Notice what the formula is for the secondary attack rate. Number of secondary and tertiary cases divided by the number of susceptible cases minus the number of primary and co-primary cases. So we're not going to have the primary and co-primary cases there, and we're going to multiply by 100%. Now let me take you through this so you understand it. So we have 12 people who are secondary and tertiary cases in this example. And so we take, that's the people that we're interested in. The susceptibles in this particular case is 54. So this should be a division sign, and it is down here. So we have 12 divided by 54. Now, in this next example, we don't take into account the primary and co-primary cases. So 69 from, we just don't take that factor into account at all, but we do take into account the secondary cases. And then we want to remove the primary and co-primary cases, so we subtract 69 from 168 to give us 99. And again, we take into account the secondary and tertiary cases, and then we subtract the primary and co-primary cases from the susceptibles. And let's see, we have 82, and we continue this process right on down as we complete the table. The percentages then is 12 divided by 54 times 100 gives us 22%. So as we look at this, I would ask you to carefully do some analysis as we have focused on the formula. And the question becomes is what age or age groups would be your priority and why? Well, how are we going to ascertain that? What we would do is we'd look at these percentages, and if we're looking at where we would spend our time, we'd probably spend our time with those who are from 2 to 9, right? If you're combining 68 and 54%, these are the two highest groups, so those would be deserving of your time. If you treated the total number of cases, it would be a very inefficient way to proceed, and it would not be cost effective. So This is why we're focusing on the secondary cases. We've already identified the primaries and the co-primaries, so they're going to get treatment. I mean, those people have been selected for treatment, and then we want to look at the secondary cases because we know not every one of the secondary cases is going to get the disease as we saw before. Okay, let me move forward here. Okay, I'd like to introduce you to a church supper, and this is a famous one, and I would be remiss in not talking about this particular incident. And yeah, people say, well, it happened a long time ago. That's true. The situation I'm going to show you is a factual one, and it's one we teach in epidemiology all the time because it was one of the very first, and so we use the same principles today that we used back then. And obviously, the reason why we have done this is because foodborne outbreaks are common. So anyway, I'm just going to read this to you so you can follow along. It says on April 19th, 1940, the local health officer in the village of Lycoming, Oswego County, New York, reported an outbreak of acute gastrointestinal illness to an epidemiologist in training who was assigned to conduct an investigation. Now, I want to also relay to you that this same process was used in a foodborne outbreak in Bloomington, Indiana, where IU is. Same exact procedures. And it was done with a particular corporation I don't want to mention, but they brought in 3 epidemiologists, 3 lawyers, the CEO, and one of his underlings. And to refute my buddy who had done the investigation in just the way I'm showing you and we'll be talking about. When Dr. Rubin arrived on site, he learned from the health officer that all the patients had attended a church supper held on the previous evening, April 18th. Family members who did not attend the church supper did not become ill. Now that's an important fact. If they'd gotten ill at home, as well as the people that had gotten ill by attending the church banquet, we couldn't restrict the occurrence of the disease or the outbreak to the church supper. It would involve more than that. Accordingly, the investigation was centered about the circumstances surrounding the church supper, and you can understand why. Next up, interviews regarding the occurrence of symptoms, the data and hour of onset, and the food served at the church supper were completed on 75 out of 80 persons known to have been present. So this is remarkable that they had that many people that were still available on which they could collect this data. Normally you don't have that high of response rate. And a total of those 75 people that they could collect data for had GI illness, or they had gastrointestinal illness. Now I want to show you that I want to talk to you a bit more that the supper was held in the basement of the village church, and many of you have attended similar things, and many members of the congregation contributed food dishes, so you could call it a potluck or a pitch-in or whatnot. The supper was held from 6 p.m. to 11 p.m., and That's a long time, by the way. That's 5 hours that this supper was going on. And food was placed on a table and consumed by visitors over a period of several hours. So um, that 5 hour period, again, is a long period to have food out and available. Now, what are the facts? Well, here's one of them. The illness was an acute gastrointestinal illness. The people who did not attend the supper did not get sick, whereas many of the people who attended the supper did get sick. We got 46 of them that got sick. So when you look at it, 46 of 75, we're talking about nearly 2/3 of all the people who attended were interviewed and that got sick. That's a high percentage of people that got sick. And remember, it's a high incidence. It's not a rate because we're not doing any particular math. We have it in a percentage form. But an incidence of 46 cases far exceeds the 2 cases required by the CDC for a foodborne outbreak. So definitely when we look at the endemic state, it's greater than 1, and when you look at 46, it's far greater than 2. So that's how you would interpret that information thus far. Okay, what are the facts? Various attendees contributed food. And this always increases the possible sources of contamination. For example, soiled hands, unclean cooked surfaces, improper holding temperatures, or purchasing food from a contaminated source. And another thing that you would want to be aware of and should be aware of these are the holding temperatures. We want food held, especially in a smorgasbord or where food is going to be left out. It should be hotter than 140 degrees Fahrenheit or 60 degrees Celsius. If it's cold, it should be below 40 degrees Fahrenheit. And so those two temperatures are ones that you want to keep in mind. So if you're looking at a cooler, a large cooler or a refrigerator, you want to make certain that it's 40 degrees or lower. I was in a situation where the food was not, it reached 45 to 50 degrees, and we had to clear the refrigerator. It was a big refrigerator. It was a big dining facility, and all that food had to be thrown away because it was contaminated. And and if you're going to freeze it, you want it below 0 degrees or 0 or below for Fahrenheit. Now, I know you all don't have thermometers and our food thermometers, and you don't carry them around with you. I jokingly have said to other classes that I've taught that maybe it would be very wise to put one in your purse or carry it on your person in some place and slip it into the food container to see how hot the food is being retained at in terms of temperature. And usually what you'll find is it's not 140 degrees. And the reason if it's 140 degrees is the food tends to dry out rapidly. And so they can't use it as long. And it doesn't taste as good, so they have to throw it away. And if you're looking at products that are supposed to be kept cold, oftentimes they're put on ice and the ice melts and that ice isn't replenished, and so the proper holding temperature for cold has been exceeded. So those are two very critical and important factors that you ought to know about, and especially if you're responsible for a a church supper, or you're attending a large gathering where food is being served, or you're hiring a caterer for a given event, you would want to know about holding temperatures, and you would want to make certain that they knew about holding temperature as well. One thing I did want to mention, that I mentioned that there were 75 out of 80 people that we could still contact. So the response rate in our case was 93.75%, which is remarkable, because again, if people would have left, then we would have needed to track them down to begin to ask them a series of questions that you will see that I'm going to be asking you about here in just a minute. Okay, these are 4 key terms that you need to know. These are 4 key terms that you need to know, because they're going to help you in determining who's sick and who's not sick, and who ate the food and who didn't eat the food. And let me just go through these with you. And if you once memorize them, they're pretty easy, and you can see how charts are developed based on them. Ill and ate it means ill and ate that particular food. Not ill and ate it. Ill and did not eat it. Not ill and did not eat it. Okay, so in epidemiology, we often work by 2x2 contingency tables, and you can see that this covers every possibility. So I'll show you how we're going to use this information as we review the upcoming slides. Now, this is what we call an unorganized or a random listing of cases. Now, if you look at this very carefully, you'll notice the case numbers are all in the right order. Okay, so they're consecutive, and I want to go on to the next one, then I'll come back. And it goes down to 75, just as we talked about initially, as the number of people who were present. Okay, the next 2 things that they gathered was information about age and sex, and the time of the meal, when they sat down to eat the meal. Okay, so the time of the meal, and then whether they became ill or not, and the date of onset, what time did they eat it, and the time of onset of the symptoms. Okay, and the ends have to do with no, they didn't eat it, and yes, they did. So you got an N and a Y. So N for no and Y for yes. And you can tell these are all the foods that were there that they thought were important to keep track of. Okay? So now it's random. The reason why it's random, the list is perceived as random, because they aren't organized or sorted according to whether they are ill or not. Okay, because those were the key things that we wanted to ill and ate it, and so on. So to organize it, we were going to sort it into 2 groups. Those that became ill, that would be the yeses, and those that didn't become ill. Okay, so let's look at the next one. And it's the same way. It's random, it's mixed up, and it's not organized in a fashion that's correct. Okay, same information. All right. Now I'd like to take you to I'm going to address the incubation period. And this is, after a person sits down for a meal, when we're talking about incubation period, and this is a very important term, again, it's covered in the Control of Communicable Disease Manual. So if a person eats a particular food that's contaminated, how long is it before he or she becomes ill? This is important information that will help us identify the food that is responsible for the illness. Okay? And I want you to know that latency is synonymous with incubation, and we want to know how the incubation period and the clinical symptoms help to determine the diagnosis of a disease. And I'm going to show you. Okay, now this is just information that I thought that you would like to know. We're always wanting to know, okay, I have symptoms. Now, when is it that I'm going to display illness? So, with the common cold, it's 12 to 72 hours. Strep throat, you can go right on down and you can see how long it's going to be. And we have them, the point of the chart is some of them are in hours, some of them are in days, some of them are in weeks, and some of them are in years. So, just something for you to take into account. Now, these are pathogens for foodborne diseases, and staphylococcal. Uh, we're looking at the pathogen, and we're looking at the incubation period, and it's 30 minutes to 8 hours, or usually 2 to 4 hours. And you can go down and read the time period for each one, but those time periods are going to be critical to us in incubation period, because we're going to compute or figure the incubation period from the data that I just showed you. Okay, so and you'll be able to see which one best fits our data. Now, these are the 5 deadliest foodborne illnesses. Now, some of these you know about, some of them you don't, but I encourage you again to go through the Control of Communicable Diseases manual. We purposely left it this way so that you might take more of an interest in learning more about these, and seeing what they are and when they occur, and their incubation period and their duration, and the proper methods to treat them. So, in each one of these will be listed in the Control of Communicable Diseases manual. Okay, now this is a disease course. Okay, we've talked about susceptibility, and we talked about those occasions that make you more susceptible to illness. And we know about the incubation period. So at the beginning of it, I don't feel good. How long is it before I show signs and symptoms? Okay, so and it's also called the latent period. And then, so we got exposure, we got a pathological process and change within the body that's occurring here. We've got the onset of symptoms, and we got the clinical phase of being sick and feeling lousy and maybe being bedridden, and then the onset of recovery. Now, I want to point out real carefully here, that it doesn't go through each of these. Not every disease is going to result in disability or death, and hopefully the outcome is recovery. Okay, next what I want to do is I want to show you an organized line listing of those ill and those not. And if you take just a minute, you can see that we're organized. We've taken the cases that were all ill, right? And you can see, and this is how we organize them. Every one of them is a yes, and I'll explain the other values here in a minute. And then on the next one, and it's very important to know which of these that you're using to come up with a total number of cases that you're going to be counting to go into a chart soon. Okay? So how we have organized the second page is these are people that, all of these people are not ill. So if you go back, we have ill and we have not ill. And then we're going to have ill and ate it, ill and didn't eat it. And then on this page, we're going to have not ill and ate it, and um, not ill and didn't eat it. And those are those four statements that I was talking to you about earlier that you've got to know, and you got to know which page you're counting data on. Now, with this particular example, you can count the wrong information. You can be on the first page and counting yeses and nos and come up with the same answer as you were if you were using both pages. So I warn you that it can be tricky if you don't count the information on the correct page. All right, let's go on to the next slide. Okay, now remember, these are the four statements that I thought were important for you to know, and I've already talked about a little bit. Ill and ate it, not ill and ate it, ill and did not eat it, and not ill and did not eat it. Okay, so you have two for each. You have ill, and that's the Y page, and you have not ill, that's the no page. So yes page, right, 1 and 3, no page 2 and 4.